Good morning everyone. This is Dr. Balamanikinda Srinivasan, Associate Professor, Department of Oral Maxillofacial Surgery from Vinayaka Mission Sankaracharya Dental College. Today we are going to see about cyst of the jaws in relation to its management. This is my lecture outline. Briefly I will be telling about the cyst, then we will be seeing about the management options available. A cyst, basically this is a pathological cavity which can have fluids, semi-fluids or gaseous content which is not created by the accumulation of the pus. Normally a cyst will not have a pus. In case if a cyst has a pus, then it is called as infected cyst. Most of the cysts, but not all, are all lined by epithelium. As you see in this picture, you can have a wall, lumen and a lining, and you can see the epithelial lining. This is a histological picture. You can see the epithelial lining. Okay, most of the time the cyst is lined by the epithelium. Now coming to the classification of the cyst, this is the most popular classification given by Scheer et al. In 2005. The cyst can be classified into epithelium and non-epithelium based on the epithelial thing they have. Okay, so epithelial cyst, non-epithelial cyst. Examples of non-epithelial cyst include solitary, aneurysmal and Staphyni cyst. Again, epithelial cyst can be subdivided into odontogenic and non-odontogenic. Odontogenic means it is formed from the tooth forming cells. Non-odontogenic, it is the otherwise. Okay, so examples of the non-odontogenic include nasopalatine, nasolabial and median cyst. Odontogenic, again it is further subdivided into developmental and inflammatory. The examples for developmental are odontogenic keratocyst, dentigerous cyst, eruption cyst, lateral periodontal cyst, gingival cyst and COC, which is otherwise called as Gorlin cyst. Inflammatory cyst includes the radicular cyst and the residual cyst. The most common category we are going to see is from the developmental and the inflammatory one. So apart from this, you can have cyst from the maxillary antrum and cyst originating from the soft tissues of mouth, face and neck also. There are few examples given in the slides. Now coming to the chair side investigation, it is a very easy one. We can do the aspiration of the cystic contents. Usually this is done with a wide bore needle, 18 gauge. If the aspiration is unsuccessful, it may indicate a presence of the solid tumor. In case if there is an aspiration of the fresh blood, this can indicate the hemangioma or a vascular nature soft tissue mass. Other aspirants, if you get, you have to submit to the biochemical analysis. So based on the aspiration content, the cyst can be identified. In case if it is a dentigerous cyst, the aspirate will be clear, pale, straw colored fluid and the protein content will be usually more than the 4 grams per 100 ml. If it is odontogenic keratocyst, there will be a dirty cream white because of the keratin material and the protein content is less than 4 gram per 100 ml. In case if it is a radicular cyst, you have again clear, pale yellow straw colored fluid with cholesterol crystals with a total protein content of 5 to 11 grams per 100 ml. In case if it is a solitary bone cyst, the content will be serous fluid or it may be sometimes an empty cavity also. Staphyni bone cyst, usually it is an empty cavity. Infected cyst, obviously as the name indicates infected, the cyst will contain the pus, okay, and polymorphonuclear leukocytes can be there. Gingival cyst will have a clear fluid. So this will give an idea what type of cyst it is. But remember, only based on this you can't come to a final diagnosis. Only the biopsy is going to give the final diagnosis. This is an example of an aspiration. As said before, you have to use a wide bore needle and you have to aspirate. You can see the pale straw color fluid there, and based on the aspiration you can assess what type of cyst it can be. This cyst has to be given to, this content has to be given to the biochemical analysis. So as I said before, the final diagnosis has to come through only biopsy. Biopsy is done to facilitate the microscopic examination of the tissue which is retrieved. It can be a excisional or the incisional biopsy depending on the size of the cyst. If the cystic size is very small, you can excise that or enucleate that, or if the cyst is large or big in size, a small portion of the lining can be submitted for the biopsy and confirmation of diagnosis is only through the biopsy. So every cyst has a typical location. The most common location, if you see here in this picture, the nasolabial cyst, the typical location is between the lateral incisor and the canine region, and the incisive canal cyst, between the two central incisor where the incisive canal is there. Radicular cyst is mostly associated with maxillary anteriors and in relation to the non-apical teeth, and you can see the dentigerous cyst here, most of the time associated with mandibular posterior angle and ramus region, and also associated with an impacted third molar, okay, impacted teeth. The common cyst which is associated with an impacted teeth is dentigerous cyst, and you can see a residual cyst here which is associated with the already extracted socket. It is mostly seen in an edentulous site because of the previous uncareful done enucleation or the surgery. The remnants of the cyst remains, and it may be many times the accidental finding. You can see the residual cyst. And traumatic bone cyst, you can see here with the characteristic scalloping, okay. Scalloping can be seen in the radiographs, and eruption cyst mostly associated with the erupting teeth. Staphylococcus cyst as such is not a true cyst, it is a defect which is found in the lingual side of the mandible. Most of the time it is an accidental discovery, and many times it does not require a treatment. Now, having said about the classification and the types of the cyst and the aspiration, importance of aspiration, biopsy and the typical location, now we are going to see about the management of the part. How a cyst has to be managed and what all the options available for its management. The basic surgical goals. What all the basic surgical goals? There are two goals. One is the eradication of the pathology. Remember, in any lesion, removal of the entire lesion is very important, and prevention of recurrence is also very important. And after that, it is not only the removal of the lesion, you have to functionally rehabilitate that, okay. So the defect what you are creating after surgery can range from a mild obliteration, depending on the size of the cyst. It can range from the mild obliteration to, it can range to hemimandibulectomy also in case the cyst is very large. So the rehabilitation, the reconstruction procedure, you have to plan before the surgery itself. So these are the very basic things: eradication of pathology and functional rehabilitation. So why you need to treat a cyst? Okay, what are the reasons why you have to treat the cyst? Okay, so because the cyst tends to increase in size, they can cause displacement of the teeth and disturbances in occlusion. So you have to treat them. Cyst tends to get infected. Yeah, they can get infected, cause pain, it can cause pus discharge, so they have to be treated. Large cyst can weaken the jaw, which can result in a pathological fracture. Pathological fracture is nothing but a fracture caused due to pathology. Okay, so the cyst has to be treated. Some cysts, they have the potential to have dysplastic changes. Okay, the tumorous growth, the cancerous growth can come from them. Example, ameloblastoma, mucoepidermal carcinoma. So they have to be treated. Cyst prevents eruption of the teeth, especially this is in the growing children, and the cyst can encroaching the neighboring structures such as maxillary sinus, nose, adjacent teeth. They can cause disturbances to them, so they have to be treated. Now, before doing a surgery, what all the factors going to determine the choice of the surgery? So first of all, you have to see the patient's age and the general health of the patient. If a patient is having, in case, any systemic diseases, the medical history, all those things has to be evaluated. And coming to the local examination, you have to see the size of the lesion, if it is a small, if it is big, and you have to see the number of the lesion, a solitary lesion or it's a multiple lesion, and you have to see the location, whether it is located anteriorly, posteriorly. You have to see presence or absence of the infection is also a important thing, and whether the cyst is has a perforation of cortical bone or soft tissue, adjacent tissue. These are all we have to see with the help of the radiographs, especially the CT ones. and whether it's a cyst is occurring for the first time or it's a recurrence, we have to see about that. And the histological variant, after the biopsy report has come, we have to see what type of histological variant it is, and patient reliability to follow up, how the patient is getting motivated for the treatment and how is cooperative, everything has to be considered. And coexistence with the syndromes like nevoid basal cell syndrome or any other syndromes has to be, everything has to be thought before going to the surgery. Now, what all the treatment modalities available for treating a cyst? Broadly, they can be divided into marsupialization, enucleation and resection. You can see here marsupialization, enucleation and resection. These are the main modalities of the treatment for a cyst. Again, in marsupialization, they are divided into subcategories like PARSH 1, modifications such as Waldron's procedure, marsupialization by opening into maxillary sinus. These are all the subdivisions inside the marsupialization. Enucleation, again you have few types like enucleation packing, enucleation with primary closure, enucleation with curettage, enucleation and peripheral osteotomy, all those things like you have many types of enucleation. And resection, depending on the jaw bone where it is, whether it's a maxilla or mandible, and depending on the size of the lesion, you can be a segmental or it can be a marginal mandibulectomy. Again, in maxilla it can range from a partial, subtotal and total maxillectomy. Now, coming to the each procedures, okay, the procedures for treating a cyst. The first one is the decompression. Okay, the decompression of the cyst is achieved by decreasing the intracystic hydrostatic pressure, which is responsible for the cyst expansion. What happens? Due to the intracystic hydrostatic pressure, the cyst is expanding. So, what the decompression aims, it reduces the intracystic pressure so that the cyst expansion is prevented. Subsequently, decompression also allows by for the formation of the bone remodeling and bone filling. Decompression is an LA procedure, local anesthesia itself we can do. It is done by opening the cyst wall and keeping the wall opened patent by keeping a surgical drain. For this, you can use an acrylic tube, polyethylene tube, nasopharyngeal airways, and you can fix them using the sutures, and by keeping the cystic patent, the lumen is flushed twice or thrice every day with the saline wash. Cysts of lower jaw are normally evacuated through the oral cavity, and in case if the cyst is in the maxillary bone, it can be either drained inside the oral cavity or the maxillary sinus or into the nasal cavity. Here you can see the picture of a mandible bone, the top one, and you can see the cyst line is opened and kept patent by introducing a acrylic tube there. Okay, so typical example for a decompression. Again here you can see the decompression and the evacuation of the cystic content through the oral cavity here in the lower picture. Now, coming to the next procedure, marsupialization. This is one of the most important treatment for the cyst. So, PARSH 1 operation, it is a surgical procedure where the cyst is modified or de-roofed to convert into a pouch. This is a self-sustaining stoma or an outlet, which in turn reduces the intracystic hydrostatic pressure. Both decompression and marsupialization aims to reduce the intracystic hydrostatic pressure. Okay, so it is a basically surgically externalization of the cystic cavity by creating a opening in the superficial aspect of the cyst. The resected portion is sent for the histological examination to know what type of cyst it is. The remainder borders of the cyst, they are sutured around the oral mucosa, converting them into an opened pouch, exposing the cyst lining or epithelium to the oral environment. So, by doing this, there is a decrease in volume and size of the lesion, which fastens the healing procedure and new bone formation also. This option is more precise and when compared to the decompression procedure. Marsupialization may be used as a solo treatment regimen for a cyst or as a prior step to the final second stage enucleation. So, marsupialization can be alone used or it can be combined with enucleation also. So, where all you will do marsupialization? In an young child with developing tooth germs where you no need to do the extraction, okay, so you do a marsupialization. When the cyst is very near to the vital structures like nerve artery, all those things, blood vessels. When it is possible to create an oral antral fistula, then you have to do a marsupialization. When the access is very difficult, then you can do marsupialization, decrease the size of the cyst. When you want assistance in eruption of the teeth, then you can do marsupialization. In an unhealthy patient, when the cyst size is very large, then go for a marsupialization. Contraindications, when you should not do marsupializations. Okay, in an odontogenic keratosis, because the recurrence is very high, usually the marsupialization is not advised. It's not recommended. Cyst with a high recurrence rate, again, when it's a smaller cyst, you can better do an enucleation. The whole cyst can be removed. Then you no need to do the marsupialization. Okay, so these are some of the contraindications. So the surgical steps, how are you going to do a marsupialization? First of all, you have to give a LA, and after the LA, the cystic content is aspirated, and you can submit the aspirant content for analysis. If the aspirate conforms the cystic contents, then you can give an incision made to create a large window in the cystic cavity. After that, you can see two choices, like whether the bone can be thinned or the bone can be thick. If in case the bone can be thinned, okay, due to the expansion of the cyst, incision can be extended into the cystic cavity. The tissue contents can be submitted to the pathological examination. Now, in case if the overlying bone is thick, then what you have to do? You have to create a osseous window, bony window. You have to create a bony window with the burr. Then you have to incise the cyst to remove a window of the cystic lining, submit for the pathological examination. Then you can irrigate the cystic cavity, examine the residual area. What all you have to examine? You have to see the presence for an ulceration or thickening, because if they are there, you have to suspect the dysplastic or neoplastic changes in them. In this case, incisional biopsy of the suspicious area also should be done. Then suture the cyst mucosa with the oral mucosa. This is a very important step. Thereby you create a pouch, like open pouch like that, then which will facilitate the reduction of the size of the cyst. Pack the cavity with the tincture of benzoin or whited varnish. Whited varnish is composition benzoin 10 grams, iodoform 10 grams, storax 7.5 grams, balsam of 12 to 5 grams, solvent ether 100 ml. So this is the composition of the whited varnish. Leave the pack for almost 10 days to 2 weeks. Then change the pack after every 2 weeks. Carefully examine the cavity, and clear instructions has to be given regarding cleansing the cavity. Instruct the patient to clean and irrigate the cavity regularly with oral antiseptics and the disposable syringes. Cavity must be repacked until the cyst size contracts. Once epithelialization takes place, the pack can be removed and it can be replaced by a single acrylic plate, as you see in this picture here. Okay, this is a single acrylic plate which is plugged there. At this stage, the patient can wash out the cavity after every meal until the cavity closes. Okay, this is a picture of marsupialization where you can see the removal of the cystic content, and the cyst sac is sutured with the oral mucosa, converting the cyst into a open pouch. Okay, so what will happen? This will facilitate the evacuation of the cystic content, thereby it will also allow the reduction of the size of the cyst. You can see the cyst here where the cystic sac is sutured with the oral mucosa. Okay, again the same picture. This is example of a cyst in the maxillary bone. There is a cyst there, and again the same procedure is repeated. The scissors used to complete the excision of the window of the mucosa. Oral mucosa and the cystic wall is sutured together all along the peripheries. Okay, facilitate the reduction of the cyst. Again one more example. The incision is given and the lesion is exposed in the second picture, and suturing of the cyst mucosa with the oral mucosa, and packing the cystic cavity with the ribbon gauze containing whitehead varnish. You can see that ribbon gauze packed in this picture. Now what happens due to marsupialization? There will be a shrinkage of the cyst. You can see the original dimension of the cyst in the first picture. So after doing marsupialization, you can see how the size of the cyst got shrunk in the second picture. Okay, So what all the advantages of marsupialization? I have told the indications, I have told the contraindications, I told the surgical steps, how it has to be done. Now, what is the use of doing this marsupialization? What are the advantages? Why you have to do that? Because this is a simple procedure and it spares the vital structure. If it is very near to the nerve, it's better to do a marsupialization. Reduces operating time and blood loss. It's no risk of creating an oroantral fistula, oronasal fistula and pathological fractures. Allows eruption of the teeth. Helps in shrinkage of the cyst and alveolar ridges preserved. So these are the few advantages of the marsupialization. What are the disadvantages? Yes, you have disadvantages also. You are not removing the entire cyst here. You are removing only a part of the cyst. So the pathological tissue is left in situ. That is the most important disadvantage of marsupialization procedure. Histological examination of the entire cystic lining is not possible because you are not removing the entire cystic lining. Prolonged healing time, yes, as it takes time for shrinkage, so the healing time is prolonged. There is a periodical irrigation you have to do and change of the packs, so the patient has to frequently visit. Second surgery may be needed, as I told before. Sometimes after marsupialization you have to do an enucleation, so in this case a second surgery has to be done. So that is also one of the disadvantage. Inconvenience due to the frequent visits, periodical changing of the pack, due to the maintenance phase, all those things. Because of that some inconvenience can be there. So this is also one of the disadvantage of marsupialization. Now coming to the next procedure, enucleation. So what does enucleation means? Enucleation refers to complete removal of cyst. Marsupialization, what you have done? Marsupialization, you have removed only a portion of the cystic content. But in enucleation, it's a complete removal of the cyst. Okay. Enucleation can be combined with adjuvant modalities to eliminate the microscopic pathologies. You can do a peripheral osteotomy, you can do a chemical cauterization, okay, with Carnage solution. I will tell you about the Carnage solution later. And you can do electrocauterization, cryotherapy, multidimensional sequential treatment, all those things are all there. Now, enucleation, when you will do? When the cyst size is very small, you can remove it. Full cyst can be removed. Can be done when the vital structures are not involved. Should be employed with any cyst of the jaw that can be safely removed, unduly sacrificing the adjacent structures. Contraindications. In young patients with erupting teeth, it is contraindicated. You should not do. You have better to do a marsupialization there. In a medically compromised patients, all debilitated patients, it's contraindicated. When the things are proximal, when the cyst is very close to a vital structure, then don't do it. In a very large cyst where the risk of fracture of the jaw is there, then better don't do the enucleation. Now, coming to the enucleation procedures, it's also called as part 2. The procedure starts with the administration of LA, then you elevate the mucoperiosteal flap, extract the involved teeth, then assess through the osseous window. Thin blade curette is used to cleave the cyst lining from the bony cavity, and you should take care not to tear or you should avoid tearing the cyst lining. Okay, so inspect the socket after removing the cyst lining, remove the remnants if any, do a watertight closure. Eventually, after this watertight closure, this cavity will be filled with the blood and they get organized into the bone at a later stage. For medium sized cavities, external pressure dressing can be given for about 24 to 48 hours, and after that you can remove it. Basically this is done to reduce the swelling and size of the clot, and formation of the bone in the cystic cavity normally it may take until 6 to 12 months. You can have a periodical checkup through radiographs and you can confirm the bone formation in the cystic cavity. And this is basically the procedure. You can see a cyst. The most common cyst associated with an maxillary anterior tooth, non-vital tooth, is the radicular cyst. And after giving LA, then you have to extract the teeth. Then you have to cleave the cyst in the second picture. As you see in the second picture, you have to cleave the cyst from the bone, avoiding the tearing of the cyst lining. You have to carefully cleave them, and once it is done, the whole cystic lining is removed, as you see in the third picture. So this is an example for the enucleation procedure. The same thing which is done in the mandible, you are shelling out the entire lesion. This is the cyst, and you can see the shelling out of the, in the second picture you can see the shelling out. You are separating the cystic lining from the bone and you are shelling out the entire lesion. Okay. Now again, cyst is there in relation to the tooth, and there is an elevation of the flap, extraction of the teeth, and since there is a bone on the cyst, you can remove with the help of a ronger or a burr also. Then the cystic lesion is removed as you see here. After that you can primarily close with the sutures, okay, like how you see in this top and the bottom pictures. So this is enucleation with primary closure. Now what are the advantages of doing an enucleation? Entire pathologic tissue is removed, and because of that the chance of recurrence is very less. That is the most important advantage of enucleation. Healing time is reduced. There is a rapid healing, reduced post-operative care. When you compare to the marsupialization, here the post-operative care is you have the reduced very less time. Enucleation with primary closure eliminates need for repeated appointments. This is what I was telling about the reduced post-operative care. Need for repeated appointments like packing again, irrigating, adjustment of the plug, this is not there in enucleation, okay, but it was there in marsupialization. Okay. So the entire cyst lining can be examined thoroughly because you are removing the whole lesion. Now there are some disadvantages also. After primary closure, observation of the cystic cavity during healing is not possible. Since you have primary closed it, you can't observe the cystic cavity. In young patients, the unerupted teeth in a dentigerous cyst will be removed with the lesion. Removal of the large cyst may result in a fracture, so you should not do that, and it's a contraindication and it's a disadvantage also. Damage to the adjacent vital structure is possible. It can lead to pulp necrosis. Adjacent tooth can get devitalized. So these are all some of the disadvantages. Waldron's method. Coming to the Waldron's method. Waldron's method is nothing but this is a two-stage technique. This is a combination of marsupialization which is followed by enucleation. I told you before, marsupialization can be done as a single procedure, but sometimes it is combined with enucleation also. That when you combine with enucleation, then it's called as Waldron's method. When the bone has covered the adjacent vital structures, when adequate bone fill is needed, when patients find it difficulty to cleanse the cavity, to detect any occult pathological condition, you can go for this Waldron's method. Spares vital structures, accelerates healing process, development of thick cystic lining. Enucleation will become easier after when the cyst lining becomes small and become thicker, then the enucleation becomes easier, allows histopathological examination of the residual tissue, then combined approach reduces morbidity also. So, but the disadvantage is patient has to go for a second surgery and any possible complication can be associated with the surgery. That is one of the disadvantages of this procedure. Coming to the next, enucleation with packing, preferred in management of the infected cyst where you can't do a primary closure. Mucopharyngeal flap is raised and cyst enucleation is done as described before, but here instead of primary closure, the flap is turned into a bone cavity and half-inch medicated gauze is done for about 10 days. A change of pack is followed by construction of an acrylic plug as you do in the marsupialization. The next procedure is enucleation with curettage. After enucleation, a curette or burr is used to remove 1 to 2 mm of bone around the entire periphery of the cystic cavity. This is done to remove any remaining epithelial cells that may present in the periphery of the cystic wall, because this is very important when you are going to treat a cyst which is having more recurrent potential. Okay, like when daughter or satellite cysts are found in the periphery of the main cystic lesion, when it is incompletely removed, then you can combine the enucleation procedure with curettage. If the cyst leaves epithelial remnants, curettage may remove them, thus decreasing the recurrence. Curettage is more destructive. Adjacent dental pulps may get stripped and adjacent neurovascular bundles can get damaged. So these are some of the disadvantages here. Coming to the next procedure, resection. Resection without causing a continuity defect is called peripheral osteotomy. Resection with a continuity defect called segmental resection. Resection along with disarticulation of the condyle. Depending on the size of the cyst, depending on the areas where it is involved, you have to do the resection, you have to plan your treatment. This is a picture where you can see the resection of a large cyst. The first picture indicates the submandibular incision and thereby in the left submandibular region, and you are going incising layer by layer in the second picture, and you are proceeding towards the bone, mandibular bone. The infected cyst is again, it has been resected out, and you can see that here in this bone it has been slowly removed and the infected portion is taken out, and finally there is a closure. Okay, so this is an example for the radicular treatment. So after the removal of the bone, you can confirm the same thing, see the same thing through the OPG. Okay, there is no bone here. Okay, because of the lesion, it has been removed through surgery. Okay, so there is no bone here in this region. Now coming to the Carnage solution, it is a type of chemical cauterization. Carnage solution is originally described by Cutler and Zollinger in 1983. The contents are 6 ml of absolute alcohol, 3 ml of chloroform, 1 ml of glacial acetic acid and 1 gram of ferric chloride. It is 6:3:1:1. You have to remember this ratio. Now the Carnage solution has been modified. Now in its modified form, it doesn't have a chloroform in it because of its carcinogenicity. Now the chemical composition is without the chloroform. This chemical composition provides tissue fixation property used in histology. Its tissue cauterization property is used in chemical curettage, for example in treatment of odontogenic keratocyst. So Holmes-Smith in 1984 has found that a 5-minute application procedures has penetration to the bone to a depth of 1.54 mm and to the nerve to the depth of 0.15 mm, mucosa to the depth of 0.51 mm. Now as a summary, you can do a decompression alone, that is the placement of drainage tube, and which causes decretion in the size of the lesion. You can cause decompression followed by enucleation along with the adjunct therapy. It is a 2-stage procedure. You can do a marsupialization alone, that is creating a pouch, you can see in this picture, and converting the cystic cavity into a pouch. Okay, you can do a marsupialization followed by enucleation, which is called as the combined procedure or the Waldron's method. It is a 2-staged one, and you can do enucleation alone, and you can combine enucleation with packing, primary closure, depending on the situations, and enucleation along with the excision of the overlying mucosa, which is otherwise called as Stollinger method, and enucleation followed by various adjuvant therapies. As a conclusion, enucleation is definitely a better alternate than marsupialization because complete removal of pathological cystic lining is possible here. Marsupialization should be preferred in cases where increased morbidity and mortality and impaired defense host mechanisms is anticipated. Marsupialization can be also employed in case of large cysts, proximity to vital structures, and in young patients, as it allows for the eruption of the unerupted tooth and prevents tooth bud injury. Thank you for listening my lecture. Thank you.